Hi, I'm Lou Ann Fisher, and I'm super excited to be here today to talk to you about my professional passion, which is nurse anesthesia. First of all, I'd like to congratulate you guys all on your choice of going into one of the better professions. I love it. Of course, I'm a registered nurse first and foremost. So I've spent my whole life in healthcare, and I don't think I would change any of that. You will have moments where you wondered what the heck you were doing. I'm not going to lie, but they won't stay very long because then something's going to happen that's going to humble you and make you realize, that compassion button's going to get pushed and you're going to remember all over again why you chose the career you did. So, first of all, just congratulations. And I know that a lot of you are probably getting close to graduating, so that'll be super exciting time also. So let me minimize myself just a little bit here. So let's get on with the talk here. So nurse anesthesia, um, what is it all about? Well, nobody knows, honestly. Nobody knows what anesthesia is. As far as anesthetist, nobody knows what a nurse anesthetist is. Nobody knows how to say anesthetist. Nobody knows how to spell anesthetist. If they can say anesthetist, they can't spell it. If they can say it and spell it, wow, they're a rare one, and they probably don't really know what we do. But unless that they've been an operating room nurse, they know. A physician, that a surgeon that works in there, they know. Unless you've done some research and you've gone out of your way to find out. Most people really don't have a clue. So I get called an esthetician. All they have to do is look at me and they will know I'm not an esthetician. My skin has a long ways to go to be an esthetician. I also get called anesthesia, which I kind of like that one. That's kind of a fun one. But and some people just go for the acronym CRNA, which we are a certified registered nurse anesthetist. So that's a fair thing to call us. But a lot of times that even gets messed up. So it ends up being a CNA. Let me tell you, I've been a CNA and I've been a CRNA, and they're not the same thing. Not at all. The days don't go the same. The background isn't the same. So it's been kind of a public image problem because of the name. Nobody can say it. Nobody knows what we do. They can't come into the OR unless they're under anesthesia, which renders them unconscious or at least amnestic. So it's kind of a mystery what a nurse anesthetist is to most people. Um, for this reason, we've kind of trended towards using the term nurse anesthesiologist, and patients love that. It's very clear. The clarity is so much better because the physician anesthesiologist a few years ago went to using that descriptor instead of just anesthesiologist. They started calling themselves physician anesthesiologist. So it kind of makes sense. It goes right along with that to be called a nurse anesthesiologist. So, of course, there's some kickback about that. And as you can guess, primarily, if not exclusively, it is from the physician anesthesiologist. And their claim is that it blurs the lines in between a physician and a non physician. And they claim that we're trying to give the impression that we're a physician by calling ourselves an anesthesiologist. Well, that's not true because we're not calling ourselves that. We're calling ourselves a nurse anesthesiologist, just like they are calling themselves a physician anesthesiologist. So, if anything, it clarifies the lines. Anesthetist is a difficult one. A lot of people don't know. Is that a doctor? Is that not a doctor? In some countries, it is a doctor. In this country, it's not a doctor, but really just don't know. I get called doctor. Not that unusual for me to get called a doctor because people don't know, are you one or not? And I am quick to use that opportunity to do some teaching, some public teaching, and tell them I'm not a doctor, that I'm an advanced practice registered nurse, and that I do the same thing anesthesia wise as a physician. So I do use that as a teaching moment, but I'm proud to say that I am a nurse, not a physician. So I would never try to blur those lines. And the term nurse anesthesiologist is a descriptor. It's not a title any more than what theirs is. So anyway, that doesn't clear up what we are. That just clears up the fact that there's a lot of confusion. So we're going to get into what we are. But first, let me just tell you who I am, why I'm here on your screen, and a little bit about my professional background. So I've been in nursing for my entire adult life, which has been a long time. I graduated with a bachelor degree in nursing. I got a scholarship out of high school to go to a diploma program, and thankfully we ended up moving to a different town. And that town, when I went to check, didn't have the typical diploma program, which was the common thing at that time. They had a bachelor degree, and I was like, oh gosh, now I got to go 4 years. It's so stupid. Why do I have to do this? Well, it ended up being one of the best. Not really mistakes at all, because it just one of the best twists in my career that could have happened, because the diploma nurses that I've met are super awesome. They're very great at what they do. It's just it limits what you can do from there for advancement. So I got out of my 4 year degree and I started my first hospital job. I was making $8.16 an hour. Woo! Big times. I'm telling you what, I was like on top of the world. I went out and bought a little red sports car because I was making so much money. And yeah, it's crazy. Anyway, I started out as a evening shift float nurse, which means I called the house supervisor around 1:30 each day and asked where I was to go that day, wherever they needed the staffing the most, and I would go there. So I floated all over the hospital, and it could have been P's, it could have been med surge, ortho, um, OB. I did just postpartum. I did not do the labor part. But intensive care unit. I didn't go to emergency room or surgery, but pretty much anywhere else I would float. And so it gave me a great broad experience base out of school, because you do get all that in school, but not a real solid foundation of certainly much more than the med surge part. So, and the other thing it did was allowed me into ICU, which I probably wouldn't have seen otherwise. And I found that I had a passion for that. I loved it, and did take a job there within just a year or two. And I liked it so much that I ended up going into um, a paramedic program and graduating and taking the national registry and becoming a national registered paramedic, and did some other things like ACLS and ACLS instructor and CCRN, which is their critical care uh, certification, if you don't know what that is, and just some other things. So because I really was passionate about it, I loved being wherever the action was at that time. And that kind of led into um, flight nursing, and I did love that. And eventually, we ended up moving across country and ended up in the Carolinas. And I started working in a CVICU, which is a post open heart unit. And that offered me, I loved the autonomy for one thing, because we worked pretty much all on standing orders, which you're still have under a physician order, absolutely for sure. But you had a lot of judgment calls and critical thinking analysis that you had to do like any other nursing job. Um, like, giving potassium on your own or blood, or extubating a patient. As we all know, patients are not cookie cutters, and they don't all fit into that. Well, if they are writing these parameters, do X, Y, and Z, that a lot of them are like, well, they have this, but then there's that going on. So you did have to kind of really analyze what you were doing, and I loved that part of it. And I did like hearts also. The other thing it allowed me to do was work around some people that were studying to go into anesthesia, nurse anesthesia, and I didn't know anything about that. I was like, well, what are you doing that for? I thought they were phasing out nurse anesthetists. I heard that clear back in the 1980s that they weren't going to be around. Well, I still hear that every now and then, not as much, but we're here. We're not going anywhere, so it's not true. But the more I heard about it and talked to those people and found out about it, I did some job shadowing. I found out, yeah, I think I would like that. It's a very autonomous position and stays in clinical inpatient care instead of in management, which a lot of times as you advance up the career ladder, you end up in management and away from the patient's bedside. So I liked that part of it too. So I did apply to a few schools and I got in. I went to Wake Forest Bowman Gray School of Medicine and that's where I did the anesthesia program part. And then we did the master's in science of nursing with an emphasis in nursing at University of North Carolina at Greensboro. And I got out of there and went in to a job at a community hospital as a nurse anesthetist. That community hospital is one that stipended my way through, which means they paid my tuition, my books, and a little bit each month for living expenses in the agreement that I would come back there and work under a contract for them for a couple of years. So I did do that, and I loved doing that because I worked there as an ICU nurse as well, and that's a great hospital. So why I'm telling you that is because there's a lot of work situations, payment wise and benefit wise, as well as work structures that you can work under as a nurse anesthetist. And I'll kind of show you the evolution of those as I go through them. But so there, I was a hospital employee. The hospital treated us really well, so that was great. I had benefits, made what I thought was a really good income, and I worked in a collaborative situation with anesthesiologists in a anesthesia care team is what it's called. So the nurse anesthetist did all the anesthetics. We did everything in surgery, but the anesthesiologist would do the pre-ops and usually do the post-ops and all that. We did not, as nurse anesthetists, do spinals or epidurals because it was a hospital decision, which is typically what it comes down to also. We managed them, but we did not put them in. So as far as scope of practice, absolutely we can do that. But sometimes you have a hospital situation where the medical staff are the ones that make that decision, and who's on the medical staff. It's not nurses, it's physicians and anesthesiologists. So it was that decision there. So I didn't have that opportunity at that facility, but at the time it was fine because I was just right out of school and there was so much I was doing. So we moved back to the Midwest. I ended up working at Stormont Vale in Topeka, and there I was an employee of the anesthesiologist group. So although our work was at the hospital and at the surgery center, I was actually an employee of the anesthesiologist group. Both of those work situations, I signed over my billing rights to the hospital, and in the second situation, the anesthesiologist group, which means that they had the right and the ability to bill the insurances for everything I did and the patients for the remainder, and collect all that money and just give me a salary based on what the contract was with the nurse anesthetist at the time. So I had a salary and I had a benefit package. And, the work, that was the payment, the financial side of it. The other work side of it was I was no longer in an anesthesia care team model, which is where I was before. I was now under anesthesiology. I was being supervised, which means that there are more than 4 anesthetists for one anesthesiologist. And this all comes down to billing. It doesn't come down to what legally or scope of practice is at all. What it all comes down to is how they can bill. So what that meant was there was one physician, one anesthesiologist for about 16 different operating rooms. And so they weren't in there doing anything. We did absolutely everything from pre-op to intra-op to post-ops. And if we ever did need a second pair of hands, oftentimes if we did call out, which wasn't that often, it wasn't them that came in. It was oftentimes they would send another CRNA in. So the fact that they were there for backup was kind of a fallacy. So we did everything on our own there, and we did do epidurals and spinals there. So the good thing was I did have a full scope of practice as far as that goes. There was nothing that was limited as far as what I could or couldn't do, other than by the scope of practice within my career. So I liked that part of it, but there was some things that I did not like with the hours that it was requiring with the small children at home. I ended up taking all of that under my own control, and I quit there and I formed my own corporation and my own LLC and contracted my work out. So I went back to them. I still worked there for probably 75% of my work, only then I did it under my terms. I did it for an hourly wage, and I did not have a benefit package. I had to buy my own benefit package, but I went in when I said I was going to work from certain hours to certain hours, and after that time, if I was needed and I wasn't able to leave, then it was per 15-minute increments of charges. So they sure got me out on time then. And I also worked at that point at the VA. I worked at an eye center, eye clinic where they did cataracts and eye procedures. I did a small community hospital setting. And then I worked in Manhattan also, just as when people were needing me. And I had plenty of work, just plenty of work. But I still wasn't doing my own patient billing. I didn't bill the insurances. I didn't bill the patients. But I did bill in that I billed the places I was working for, the hourly wages, and then bought my own benefits. So it was a move towards independence financially, and it was a move towards independence as far as working in a lot of different structures in a community hospital, not having anybody else around. You're the only one, to the VA, which is, of course, the government and military, which has their own set of things going on, to the same place I had been working, and then Manhattan. So after that, I was recruited over to Manhattan, which is where I still am. I do OBGYN exclusively. So I do the labor epidurals, C-sections, hysterectomies, DNCs, diagnostic laparoscopies, and a few other things as well. But here, I am my own boss entirely. There's two anesthesia groups here, so I work for the smaller one. We equally share the caseload, but each of us has our own LLC, our own corporation, and we all do our own billing as far as to the insurances for our own cases and to the patients. So a whole different spectrum from one end to the other as far as the financial package, and then as far as the work situation, I am completely independent. So there's kind of like four different ways the anesthesia can be given as far as the setup of work structure. One is complete CRNA independence. There's like you're the only you're not under any supervision from a physician or anesthesiologist. Another one is the medical supervision, which is what I talked about at Stormont Vail. So there's more than 4 CRNAs for one anesthesiologist. And again, this all comes down to billing, not scope of practice, what legally has to happen. And then there's the other one where it's medical directed. So there's less than 4 CRNAs for one anesthesiologist, and they're telling you a little bit more hands-on what what they feel like it should be done and whatnot. And then there's the anesthesiologist only. So that means that they're doing their own cases, and that doesn't happen very often because it's not cost effective, and neither are the team models, because it's a duplication of services. It's a duplication of personnel to do the same job. So the most cost-effective one is CRNA only. So there you are. That's how I ended up here. And that is just a little bit about some of the different ways that can be billed and work situations as far as scope of practice that you can actually do as well. So what is a registered nurse anesthetist? First of all, when I found this slide, it talks about anesthesia. Obviously, that's the central word, but nursing wasn't anywhere on it. So the nursing that's written in red was added by me. First and foremost, a certified registered nurse anesthetist is nurse, and it is a function of nursing as well as a function of medicine, as well as a function of the other words on here. So it seems silly to say that, but so often that kind of is like a elephant in the room. It just doesn't even get recognized. And anesthesia is a state of a controlled temporary loss of or reduction of sensation, or awareness. It doesn't have to be both. It's induced for medical purposes. And of course, generally that's for surgery or for childbirth or like a trauma where they have horrible, maybe rib fractures and whatnot, and they need to have some pain relief. So that's kind of the quick overall of what it is. Um, some facts about nurse anesthetist. How prevalent are we? We're extremely prevalent. We're the most common form of or person that gives anesthesia in the country. There's over 50 million anesthetics in the United States given every year by CRNAs. The CRNAs provide over 80% of the anesthetics in Kansas alone, and 83% of the hospitals in Kansas rely exclusively on CRNAs, which means there's no anesthesiologists there. And if it wasn't for the CRNAs working there, they honestly, they wouldn't be able to have surgeries at that facility. And it does happen where there's small community hospitals that can no longer provide that service because they can't afford or cannot get anesthesia coverage. So it's an important role that we fill in all urban and rural areas, but especially in rural areas. Of course, we're very prevalent in urban areas as well. Rochester, Minnesota is the most densely populated area for the CRNAs, which is kind of an interesting little sideline. But historically, in the United States, nurse anesthetists have been practicing for over 150 years, which is a long time. So you may remember from your schooling, or maybe not, but around 1850 or so, that's when there was the discovery of germs and infections and the correlation in between the two. And once that was kind of discovered, that's when surgeries really started happening. And that's also when the need for anesthesia personnel really started happening, because that became very, very much a problem if you couldn't anesthetize somebody that was having surgery. So the first specialist in anesthesia were registered nurses. The mother of anesthesia, and that's actually what they call her, is Alice McGaw. And that was around the 1850s, 1860s. And she actually worked with Dr. William Mayo, who is the person that Mayo Clinics and Mayo Hospital System is named after. And she was the first one that historically gave anesthesia for a length of time, and there's some really interesting stories about her, as well as some other ones along the way. The first educational program was started around 1909, and then in 1931, Agatha Hodgkins started our National Association of Nurse Anesthetists, which was called NANA then. Now it's called American Association of Nurse Anesthesiology. So the name of that was just changed. It went to American instead of National a long, long time ago, but the end of it was just changed last year from American Association of Nurse Anesthetists to American Association of Nurse Anesthesiology. And again, that was in correlation with the name trend that is trying to kind of clarify things. So, and a couple other just real big landmark things that have happened historically for the profession. In 1986, Congress passed legislation that allowed CRNAs to get direct reimbursement from Medicare Part B, which this is important because that's what allowed us to bill patients and insurances. Before that, we had no billing ability, so we had to only work for other facility or entities that could bill. So this is really the start of what added some financial independence for one thing, but also some independence, so we could be on our own instead of working for somebody else. So it was huge. We were also the first non-physician specialty in nursing that was allowed or was granted that ability to do that. So it was a big moment. And then in 2001, Iowa was the first state that opted out of federal supervision requirements. So it was nationally mandated that CRNAs were supervised by a physician, and it wasn't for scope of practice and it wasn't for medical malpractice reasons. It was completely for billing, for Medicare billing. So if that's what rules everything, is if you can't get reimbursed, you're not going to be allowed to do it, or you're not going to want to do it. So up until that time, it was a national thing. It was just so, and around 2000 that changed, and it's now regulated at a state level, and now there's about 19 different states that have opted completely out of physician supervision. So that means that you do not have to have a physician in the area or working with you um, to give the anesthetic and bill for it. So Kansas is one of those that has opted out. So that was another big moment. And both of these have really changed the payment structure and the reimbursements as well. So other big things, as far as safety, every study shows the safety in between whether the anesthetic was given by a nurse anesthetist or a physician anesthesiologist is absolutely the same. The outcomes are the same. Anesthesia is extremely safe now compared to what it used to be, because we have better equipment, we have better ways to monitor, and a lot of other reasons as well. We understand things better, and several things. So that's a great thing. And then cost effectiveness is the other thing about nurse anesthetists. We as nurses are at the top, pretty much the top of the pay scale as far as what nurses make, but we are far less than what anesthesiologist makes. So that allows a lot more places to have surgeries, like I already talked about, that maybe wouldn't be able to if they had to rely only on anesthesiologists. Nor would anesthesiologists want to work in some of those places, because they're small rural places that, maybe not everybody wants to live. So as I've kind of been talking, you're probably hearing some of the same theme as far as anesthesia, doctor, anesthesia, nurse. So there's been this is kind of a blurry slide on the top, and that's kind of on purpose because it's a blurry topic. Some will argue that anesthesia is the practice exclusively of medicine. And obviously, I'm a nurse, so I don't believe that's true. And I probably wouldn't be allowed to practice if it was. But do you think it's the practice of medicine? We are in there giving a lot of medicines without any physician order, without any prescription. We're doing a lot of procedures that are very invasive. We're intubating people, we're putting in central lines, we're doing spinals, epidurals, we're doing all this stuff without a physician there. Are we practicing medicine when we do that? What do you think? Are we practicing nursing? I mean, it's a fair question. It's been one that's been asked over and over, and the answer is right here. If it's a nurse doing it, if it's a nurse anesthesiologist, then it is the practice of nursing. If it's a anesthesia that's administered by a physician, then it's the practice of medicine. And that was determined and backed up in court when it did go to court. So it's a constant battle. I don't know why it has to be. There's so much work to go around. There really doesn't need to be a competition or anything in between, competitiveness in between different entities. But I guess, it's the human way when it comes down to power and money, I guess. So let's talk about practice settings. We can work in a lot of different settings, and your workday may look a lot different depending on what it is that you do. Probably the most prevalent, of course, would be hospital settings and doing surgery, or OB/GYN like I am, which is the birthing center. Surgery centers are right up there with it, very prevalent. Office settings, those could include working in a dental office, especially like giving pediatric dental procedures, or oral facial surgeon, oral, maxillary surgeon. You could do a plastic surgery office, a podiatrist, ophthalmologist. and so forth. So there's a lot of different office settings. Nurse anesthetist also can do a special fellowship in a couple different areas, and pain is one of those. So I have a colleague here in town in Manhattan that has worked for the other group and since has gone through his fellowship and now practices out on his own in his own clinic doing advanced pain blocks and techniques. Um, and he does do a little bit still at the surgery center when with the fluoroscopy there. There's anesthetists that are doing ketamine clinics, which is a newer form of treatment for major depression, and Botox clinics. And then, of course, military. Um, military, the CRNAs have been a big influence and pretty much the only ones for since Civil War, and they became very prevalent in World War I, as you can imagine, because of the weaponry advanced in artillery. There was so much more trauma than what there had been before with people just having like rifles and guns, which is bad enough. But in the military, they have full practice authority completely. So they're very, very important there. That's for sure. Who could we take care of? We can see anybody at any point all across the spectrum, as you know. We do everything from newborns, neonates to geriatrics, and I'm not trying to put myself by the geriatrics. Let's move me up there, closer to the adolescent maybe. So any age, when I worked at Stormont, you could do a neonatal surgery on a newborn that was critical, and then walk in and do a 91-year-old broken hip, and go in between times those two and do a labor epidural or a C-section. So you're all over the place for ages and surgical types. There's specialties, of course, in all of those, and there are anesthetists that do specialize. Like at Stormont, I did across the board all of those. We did neuro, like brain surgeries. We did pulmonary, like lung surgeries, cardiac, heart surgeries, dental, trauma, gunshot wounds in the middle of the night. So we did all of those, but there are facilities, the bigger universities, that specialize in they each have their own specialties there. They may specialize in organ donation or only do pediatric anesthesia or whatever. So some people do get advanced training and sometimes even the formal fellowship and stay in one area versus another. So over here we have the physical classifications, which is ASA numbers are the anesthesia, their level of health, pre-existing health. So ASA 1 being the healthiest person with no disease processes. ASA 6 is somebody that's going for organ donation. So you don't see those, obviously, thankfully very much. But an ASA 5 is somebody that's probably not going to make it out of surgery. So we also add on the surgery could be a routine surgery, like scheduled, or a urgent situation where it needs to be done fairly quickly, or emergent. So we would put like an E on the end of that. Maybe if it's a ASA 2, it might be somebody with a 2E would be a patient maybe with mild asthma that's controlled well with an inhaler, doesn't have any thing that interferes with their life other than, it's able to be controlled. And then an E after that would mean it's an emergency because of whatever it is that brought them into the facility for the surgery. It has to be taken care of right away. So as far as technical skills, obviously there's a lot of technical procedures that are done, just like with nursing in general, and they can be starting central lines to intubating patients, advanced airway skills, regional blocks like the epidural spinals, tap blocks, whatnot. Ultrasound techniques have really grown also. So that's a big part of our day. Now, what about schooling? How do you get in, and how does all that kind of look? So the admission criteria for schooling is a minimum of a bachelor degree in nursing or its equivalent, whatever degree it is that took you into nursing. If it was a degree that got you into nursing, that's probably going to be accepted. And a minimum of at least 1 year critical care experience. The average is about 2.9, so it's a little bit more than that, but that doesn't mean that there aren't people that get in with just 1 year, because there are. So grades are important. Obviously, I think it's around the 3.5, but it's school dependent, and as far as the minimum on that, and as well as the GREs and whatnot. School selection criteria, you would use the same criteria to decide on where you want to go to anesthesia school that you used for nursing school, and that is the pass-fail rate is considered. You would want to look at how much experience they get in like regional epidurals, spinals, because counterintuitively, you would think you would get more experience at the bigger universities, but because there's so many teaching programs there and medical residencies and whatnot, a lot of times you're up against them for trying to get your experience, and the ones that end up coming out ahead with that, if there's a power play, is the anesthesiologist trying to get their residents in and get their experience, so you get bumped. So it's important to know, are they going out to other satellite facilities to get that experience if they're not able to get it where their primary clinical site is. And most of the schools do go to several places. It's not just one, but you do want to make sure that you're getting a good base of regional experience, as well as going out to some facilities that do have CRNAs that operate under or that perform under independent situations, like what we do in Manhattan, so that you can kind of experience that degree of, the entire scope of practice, doing all that by yourself. So you would want to consider all those. As far as the actual education and clinical, most of them programs are about 2 to 3.5 years in length after. That's, of course, once you start the anesthesia part and you've already gone through the bachelor part. And they are all, as of 2022, mandated to be a doctorate level. So the last of the ones that are master levels have already been admitted. There's nobody else being admitted that will graduate with a master's at this point. So you would be going, the didactic for your anesthesia program is done in conjunction with the program with the university that you'll be getting your doctorate degree from. So you'll kind of do those dually at the same time, as well as for your clinical at the same time at some point when you start that. And the clinical will include all surgical types, all patient types, all patient ages. And of course, you have to have a minimum of every one of those. From you have to have a minimum of so many neonates and so many within certain age groups and within certain ASA categories, and surgical types, thoracic versus lung or like med-surg or whatever, ortho, all those have to be covered. So you do get a lot of clinical experience, and of course you will be mandated to be board certified. So at the end, you do take the board certification test like you do with nursing. And like I already mentioned, the possibility of fellowship is there if you ever wanted to go on and specialize in a certain type and become fellowship actually certified. So continuing education, I'm not going to go through all this because heavens, there's a lot to it now. They just revised all this, and let me just tell you, it's kind of crazy. We just are on our first 4 years since it's been revised. So the big thing is there's 2 4-year cycles. There's a lot of things you have to do that fit into different categories in between those. And once in that 8 years, there's a test that's now in there. So I'm pretty excited about that. Yeah. Anyway, professional issues. I've already touched on some of these, just like any other profession or type of nursing. There are some things that we face as a profession that are I guess, priorities that we are looking at, one of which is the full scope of practice. Like I mentioned, we want to make sure that we are able to do what we're trained to do, what we're legally enabled to do, and not hindered there. And going from the right to the left, I guess it would be on your screen. Um, AAs, anesthesiologist assistants. Those are that's a profession that was developed by anesthesiologists a couple decades or more ago. And their goal with developing them is to replace CRNAs. I'll just be blunt. And the advantage for them doing that is that AAs, which is anesthesiologist assistants, have to work underneath the anesthesiology license. They cannot work independently. They can't bill, so they are completely enslaved to them as far as their ability to do their job. So that's an advantage if you're looking at a competitive situation. It's an advantage financially and power wise. So they've been very strongly pushed to have more and more AAs because of the same reasons I just mentioned. AAs are well educated, not as well as what we go through at all. But I don't want to say that they're, I don't want to dog on them too much. They can have a degree of any kind when they start the program. So there's a lot of differences, though. I was looking at one not too long ago that had her undergrad degree was in dance. So that's pretty helpful when you're in the operating room. Anyway, I'm probably not going to say any more about that, other than the fact that it's interesting that the nurse anesthesiologist, the descriptor that we're trending towards, the reason they don't like that is because they're afraid we're going to drop off the nurse and just be called anesthesiologist and be confused with a doctor. But the very profession that they made and modeled and molded by their own hands, the title starts with anesthesiologist. So it's an anesthesiologist assistant. So to me, if there's going to be a confusion about who's a physician and who's not, I would think that it might be an anesthesiology assistant, which they are not physicians. So the whole argument is very challengeable by anybody that knows anything about what's going on. So unfortunately, most of the legislators and public that hear their arguments don't know those things. They don't know the safety records. They don't know that we do the exact same things. And they're fed what they're fed, and whether they do their own research or not is I guess different depending on each legislator. So the other things that we look at: direct reimbursement, non-discrimination. That means that when we can do our own billing, but when we bill insurance, are we getting 60% of what a physician gets when we're doing the exact same job, the exact same everything? So in 2020, there was the rule passed, or legislature passed, that says that we cannot be discriminated against for billing reasons based on licensure alone. So we're in the making of history again to see if that is held up and whatnot. And we do make good money. I'm not saying we don't, but the fact that we're paid less to do the exact same thing is always interesting. And the other thing that's constantly on the horizon is the physician or the supervision opt-out. So state by state, trying to get more of that opportunity to practice at full scope of practice. And there are some CRNAs that don't want to do independent, and I absolutely respect that they like the anesthesia care team, that's what they're comfortable with, because that's all that they've done maybe. And that's absolutely fine. It is not a cost-effective um, model. It is the most expensive model. So if you're talking about healthcare costs, then that's a consideration. But there's no reason legally that we should not be able to practice independently. So I'm very glad for what I get to do. I love where I work. I love what I do. And if you're interested in um, anesthesia and pursuing a career in nurse anesthesia, I would suggest that when you get out of school, you do go into critical care at some point and get some great experience. Get in there where you get the most experience you can and shadow some CRNAs if you're able to go into the operating room and follow them for, a couple different ones. Also, if you have any grades that are less than stellar, which it can happen. Try to maybe think about retaking one or two of those classes if it's something that's really a problem, so you can get that grade up, if it's like only one or two. Um, and the other thing is the interview process to get in is pretty important, just like with nursing school. So talk to those who have gone through the program recently, gotten into an anesthesia program, ask them what kinds of questions they were asked and kind of some um, different tips on how to answer those. So I hope this has cleared up any questions you had or any interests that you had. And if you didn't have either of those, that at least has educated you some on our career field. It's a wonderful career and you are going to love your nursing career. And congratulations again.